Thank you all for being here. It's interesting seeing this group today, and I take great pride in having you all here with us. Jeff Stebla and I started talking, I don't know, a year and a half ago about doing this kind of an event in Western Massachusetts, and Market Street Research jumped on board, Jennings was on board, and now Silver Tech, and it's just cool to be able to bring this in a smaller, more intimate environment. You don't have to fly to Chicago or even drive to Boston. So I'm grateful that you're here, and I look forward to what we're going to share with you today. It's also cool because so many of you are my friends. Raise your hand if you know me. See, notice I didn't say if you're my friend because there would be less hands. Yeah. So a lot of friends, and I appreciate the support from our friends. When I speak at conferences, I usually speak about issues that I care about, that I'm passionate about. And I know passion is an overused phrase, but I really do. We work in an industry. How many of you work in healthcare marketing? Raise your hand. Okay, we work in an industry that's expectedly, not unexpectedly slow. We're slow to move. We're slow to adopt new technologies. We're slow to change, both on the clinical side, and the operations side, and on the marketing side. So, it's no shock that we're behind in a lot of areas. So I've spent most of my career, and today I will be talking about one of these things, trying to move us forward. And, I'm one of us, and I'm trying to move me forward and move my clients forward with me and get people like you to move forward a little bit at the same time. And I know it was in 2010, I started on this rant about physician relations. Digital physician relations in particular is my interest. But I was ranting about physician relations because I was hired by a client to put together a marketing plan to reach physicians for a health system in New Jersey. And I thought, great, I'm going to write this plan. It's going to be amazing. And like all of you, I do research first. I say, what are the best practices out there? So I did the research, and I was a little, this is 2010, so we're in the digital age at that point. And there wasn't much digital going on. And I was like, man, there's an opportunity here. And I'm not picking up what I need to be picking up just by doing my research, looking at, these different organizations. So I said, I'm going to go on one of my favorite things, which is LinkedIn, and go to all those discussion groups that I belong to. I belong to 50 discussion groups on LinkedIn. 12 of them are healthcare marketing specific. And I'm going to post a question and say, what are you doing that's really novel in the area of physician relations? And Kelly, to our conversation earlier, they said, we're having cocktail parties for physicians. We're having special Saturday outings where physicians and their families can come. We're having CMEs. You all know what CMEs are, courses where the physicians can get the credit they need to keep their licensure. That's what they talked about. And I said, what about the digital world? You're missing the point. So I said, I've got work to do. I wrote a marketing plan, and I fortunately connected with some great people who are doing really good work, because there is some really novel work happening out there. They just didn't volunteer it on LinkedIn, I guess. So today is the story of that journey from 2010 until today, working on physician relations and trying to make it contemporary and relevant, because what's happening in the world? I guess I should show you some slides. I do have slides to go with this, so here we go. My pet peeve, and tell me if you disagree with me on this, I welcome it. My pet peeve with physician relations right now, it is based on a model of interruption. Think of how physician liaisons do their job. Their whole thing is going in like the pharmaceutical reps do, knocking on the door of the doctors. First, they got to get past the gatekeeper, right? And they'll bring bagels or whatever. And they come in and they want time with that doctor. And what's the problem with that? Do physicians have a lot of time? No. How much time is the physician spending with an average patient right now? 10 minutes? I've read reports that say the patient speaks for 45 seconds before the physician is ready to render the diagnosis. That's how long that interaction is. Doctors, all the doctors I know are frustrated that they don't have more time to spend with patients. And why don't they have time to spend with patients? Because they're bureaucrats now. They're administrators. They have so much paperwork to do. Being a physician is not the same job that it was even 10, 15 years ago. So they don't have enough time to do what they love and why they went to medical school, which is interact with patients and work with these people. And yet we're sending in our physician liaisons from, whatever medical center you happen to work for and interrupting their day and making demands and saying, hey, can I introduce you to our new surgeon that we have or our new whoever it happens to be? Let me tell you about our whatever program and our new bariatrics program. To me, that's not successful marketing. Because if you think about marketing at its core, good marketing revolves around the life of the individual you're marketing to. You take into consideration what is their life, how do we fit within their life? And that is not about going into their practice and interrupting them in a busy day. Now, I think that will never go away. I think we will always do some of that, but we can supplement that with much more effective marketing. And that's what I'm going to talk about today. So setting the scene, I've already talked about this. Physicians do have less time with their patients. They don't want to be interrupted. And physicians today are much more possessive of their time than physicians 20 years ago. They want work-life balance. They expect to have time outside of the office with their family. And the whole thing about the doctor's lounge, where doctors used to go to get to know each other. Julie, I know you remember the days of the doctor's lounge. It's gone. It really is. The doctor's lounge today, okay, I'll give a prize. I'll have to come up with a prize, but I'll give a prize to somebody who would tell me where is the doctor's lounge today. How about online? Where's the doctor's lounge online today? Where doctors meet and greet and talk. It's what? Close. It's online physician communities. There are closed online communities for physicians only. Like Doximity is the hottest one right now, but Sermo, there are lots of others. Half of all physicians in America belong to one of these. And they go on there and they can share diagnoses, they can talk to one another by specialty, and they can say, look, I've got this really challenging case. They're not violating HIPAA. They can talk back and forth and trade ideas. They can talk about the newest research, new clinical trials. That is the doctor's lounge of today. It's amazing. If you're not familiar with Sermo or Doximity or one of these other, WebMD has their own physicians portal. You should check them out. They're really remarkable. And it speaks to physicians' willingness to use digital tools to speak to one another. And that is how they use digital tools. Most physicians are not using digital tools to speak with patients. They're using digital tools to speak to each other, to have those kind of colleague-to-colleague conversations. And that's an important thing to remember. So this speaks to these online communities. This was a 2014 study by the MedData Group showing in particular specialties how many of the physicians, what percentage of the physicians are joining online communities. So for some reason, ophthalmologists were very involved at the time. This has increased since 2014. Geriatrics, psychiatry, otolaryngology, and oncology, just to show you a few of the specialties. So this is real. I mean, this is a trend that has been happening since way before 2014. Doctors on Twitter. Look at this. These are tweets over the years. It's amazing. This was a 2016 study, which I recommend checking out. I think the university that did this is called Augustana University, and it's a 2016 study about physicians' use of Twitter. And it reinforced everything I believed about physicians and their use of digital technology and digital communication, that doctors are not using Twitter to talk to other doctors. To talk to patients. They're using Twitter to talk to other doctors, to share their learning with other doctors, to share studies that they found, to share new treatments, to share leading edge information. That's what they're doing. And they're also using Twitter to promote their practice and their brand. So meanwhile, all this is happening in our world. Doctors are moving down this digital pathway, and it is not a tsunami. It's not like this crazy movement to digital. It's slower. It's what you would expect from doctors. It's a more methodical process. Only about between 5 and 10% of all physicians in America use Twitter right now for their job, as part of their profession. But if you think about that, that's over 70,000 physicians on Twitter. It's huge. So it's a great opportunity, and that number is only going to increase over time. As the older physicians start to move out of the practice and newer, younger ones come into the practice. So if you want to be ahead of the curve, thinking about using digital tools to engage referring physicians is where you want to be. It's not where you want all of your effort to be, but it's where you certainly would want some of your effort to be. So we're looking at these ideas of improving the operational efficiency and value of physician relations programs. How many of you are under a budget crunch? You consider yourself pretty pressed for budget? Yeah. Well, physician relations programs that I know, they're losing FTEs. And they're having to say, how do we cover more ground with less people? And digital seems like a great way to do it. When you go physically to a physician's practice, you have that one-on-one communication. If you're lucky and you get through to the physician, that's a huge chunk of time for one interaction. What could you do with Twitter or LinkedIn or some other vehicle? My client, MD Anderson, uses Facebook to reach out to physicians, and their focus is solely cancer. They have a Facebook page that is a resource center for other physicians out there, and they have over 3,000 physicians that have joined this page. It's remarkable. Before I saw that, you couldn't have convinced me that we're going to have physicians in a professional capacity joining a Facebook page like that, but MD Anderson proved me wrong. So I researched best practices, and I saw all the usual stuff. I was most encouraged when I got to MD Anderson, and I started looking at their physician relations program. And it's hard to see on this slide, but there was a little bird down at the bottom that showed Twitter. Their physician relations program had their own Twitter feed, and it was at Phys Relations. So it was cool. I was encouraged, like somebody gets it. So that made me happy. This is the Facebook page, their resource center that I was talking about. It had 4,200 likes at that time, and this was probably 5 years ago that I took this screenshot. Mayo Clinic was using video to engage referring physicians, because if you think about physician relations, one of the big things we want to do is introduce those referring docs to our docs. That's the goal. What if you introduce them by video? So what if that referring doctor out in the community could go on your website and watch a 90-second, 2-minute video of your specialist talking about what's new and hot in the field and what they're doing? That's an opportunity. It really is. And at the same time that you're creating that video of your specialist, you could create a video for consumers too that isn't quite as sophisticated, but you're in there recording them, take an extra 5 minutes, 10 minutes, and get some good content that would be more consumer-oriented. So I love the use of video. So I did all this research, and I was working on this Cooper University Hospital referring physician marketing plan. And we created a program based on what I was able to see of best practices in the industry and ideas I had of combining the best of traditional marketing, because you don't want to throw the baby out with the bathwater, with digital marketing to reach out to these physicians in this marketplace in southern New Jersey, which, if you guys know New Jersey, this client is in Camden, New Jersey, one of the roughest communities in America. And they're making great strides to try to improve this community, but it has a very rough reputation. And a referring physician, when a patient would come to them, would be nervous about saying, I'm going to send you to Cooper University Hospital in Camden, because the patient's like, literally, am I going to get shot? Is it safe to be there? That's the kind of community this is. That's the perception that existed around it. And meanwhile, Philadelphia, you can look across the river and see those great hospitals in Philadelphia. Penn and Jefferson, and they're all over there. So for those referring docs, even ones employed by Cooper, they'd say, you know what? if I refer them to one of those Philly hospitals, they're going to be a happy camper because A, they're great brands, and B, they feel safe going to those hospitals. And physicians are low risk. The worst thing for a physician is to make a referral and have the patient say, why are you sending me there? Right? I mean, the work we've done with Tufts Medical Center, they have their floating hospital for children in Boston. How many of you, be honest, how many of you have heard of floating hospital for children? Okay, good. It is not the brand that Boston Children's is. Boston Children's is either 1 or 2 in the country for rankings of children's hospitals. It is top-notch. Not that floating isn't top-notch, but it's just a different brand. And can you imagine if you're a pediatrician in the community somewhere in eastern Massachusetts and you have a kid who's really sick and really worried parents and you're saying, we're going to send you to floating hospital for children. The typical parent would say, why aren't you sending us to Boston Children's? They're right down the road. They're the best in the world. And if you're a doctor, you don't want to confront that, right? So you just take the easy path and say, I'm sending you to Boston Children's. And we're not done with it. There's no risk in that for me. And the parents are happy. You can't go wrong referring a patient to Boston Children's. It's a great place. All right, so Cooper, we put together, this was my first time trying to create a modern physician marketing program. And this is what it looked like. The centerpiece of the whole program was a microsite just dedicated to referring physicians. And we branded the program the South Jersey Medical Report. So we owned South Jersey. We were like the official medical voice of South Jersey. And I love that. That took gall to do that. So we did it, and we created this microsite. And we would go in and interview physicians on camera. We would take the audio from that and create podcasts. Obviously, we created all kinds of videos. And we would write articles from that information and enrich their web content, their blog content. So this one source of information, going in and interviewing these physicians on camera, gave us content for multiple platforms in this program. And you can see video up front, prominent. It looks like content for doctors, not content for patients. And we never promoted this to patients. With this, we did the old traditional academic medical center medical report that would go out to doctors quarterly. And it promoted the online version. We had this as a PDF that you could download. So, but it was important. I mean, we would send 2 or 3 of these to each practice in the area because you want the different decision makers within the practice to be able to see this. And it was sometimes as much as a 16-page publication. It would have lists of all the clinical trials going on, lists of new physicians. We would feature 1 or 2 of their centers of excellence in each issue, and we had an editorial calendar that we followed for that. So it was an important piece, but the microsite was the centerpiece. And then we had our Twitter feed. You can see we're feeding Twitter updates through the Inside Cooper blog, which was the blog that went with this program as well. So this was really well-rounded. The blog, the microsite, we used Twitter, we had LinkedIn as part of the program. And here's the actual Twitter feed when it was first starting out. We had 29 followers at the moment. And then we had mobile versions, which back then, this was 2011, that was pretty good. Right, Chad? Yeah. But one of the coolest things was this program, when we were going in and digging for content and interviewing these specialists at Cooper for content, it gave us all this rich content to enrich their website, which needed it badly. All of these departments that we were interacting with really had anemic web presences. So we could go in with new content, with video content, with articles, with text that was informative, put that content on the departmental part of the website, and suddenly they had a rich website. So it served a number of purposes. And at the end of the first year, this was fast. We were marketing to referring physicians, both community physicians and employed physicians. This is data just for the non-employed physicians. And look at the way the numbers changed. So for cancer care, before the campaign, only 46% were willing to refer to Cooper. 77% at the end of year 1. The PCPs were willing to refer to heart care, 59% pre-campaign, 77% after. For neurosciences, 47 versus 75. And then look at this. So here's the anomaly, and this is why I love this data. And I generally love data, but I love this set of data because orthopedics, their willingness to refer went down at the end of a year of this campaign. And what happened 6 months into this campaign, their orthopedics team got hired away by a hospital in Philadelphia. So they had this huge void. And that told me that this data was reliable. I was like, okay, that makes sense to me. I get why those numbers went down. Because, it's so irritating to be a referring physician, and the people you refer to are now gone. And you don't even know the new people who've moved in. It's like, what am I going to do? It's almost as irritating as when you refer a patient and you never hear back from whoever you sent that patient to, which is the number one complaint I hear from doctors. I send my patient to Harvard and I never hear back. What happened to that patient? So that was Cooper. I thought that was really nice. We had some of the old school methodologies with the newsletter or magazine, but we had newer technologies involved, including Twitter and LinkedIn. Then a few years later, Tufts brought us in to do a referring physician campaign and this is the interesting twist, for affiliated physicians. These are not physicians employed by Tufts, but they have an affiliation with Tufts. So, they should refer, but there's nothing to compel them to refer. And they wanted these physicians to feel comfortable making the referral. And these physicians faced exactly the dilemma I mentioned earlier, which is, well, if I send them to Tufts, are they going to say, why didn't you send me to Mass General? Or why didn't you send me to BI or whoever the hospital is? So we had to make these physicians feel comfortable with that referral. And the first step in that is making sure the patient feels comfortable. So if the patient comes into the exam room aware of Tufts and how excellent Tufts is, or Floating Hospital for Children, and the doctor later in the conversation says, I think you should go over to Tufts, or I think I should send you to Floating. If the patient is already familiar with those organizations and knows they're high quality, there'll be less resistance. Does that make sense? So that's what this campaign was all about. You can't read all this, but part of the analysis we did up front was, what are the touch points in these practices where we can get in front of the patient? We can communicate to them in the exam room, and I'll show you how we did that. In the physician's office, we can do stuff for the physician, break room stuff for the staff. Interestingly, I spent the summer interviewing referring docs before we created this program. I went around with the liaisons for the program. The number one reason, and doctors don't make most of the referrals, by the way. It's someone in the practice other than a doctor. The doctor says, I need an orthopedic surgeon, go find it. That's really how most referrals happen. So when I was talking to the administrators of these practices who were doing the legwork to find the referral, the number one reason they didn't refer to Tufts was they couldn't find the phone number. I know, Julie, I bet that doesn't surprise you at all, does it? Absolutely. So we definitely tried to educate ourselves. So we created this program, and they had these emblems. They're not really logos, but they're emblems that we love stickies that you can put on the wall that won't trash the wall, and they're hygienic. They could be cleaned. But we could put these up on the glass walls and practices. They go on wallpaper, on sheetrock. And right off, when you walk into one of these practices, there's a sign that says, we proudly refer our patients to Tufts Medical Center, or Floating Hospital for Children if it's a pediatric practice. So immediately we're planting that seed. So it's not a shock 20 minutes later when the doctor says you need to go to Tufts Medical Center or Floating Hospital for Children. We had a microsite where the doctors could go and get anything they needed. Because when you're let's say you're in Lawrence or Lowell or wherever you are in Massachusetts, and your doctor says, I'm going to send you into Boston to Tufts or to any hospital in Boston. The number one fear is, I hate driving in Boston. Oh my God, you're going to make me drive in that city? So we had directions. We have a first visit manual that they could download for their patients. We had everything we could to possibly make that first visit easy. And that's something we don't think about. If you look at your website, go back to your office, tomorrow, or no, not tomorrow, it's Saturday. Go back on Monday, look at your website seriously and say, how have we worked to accommodate that physician and his or her patient, to make it easy for them and to overcome all those apprehensions and fears for that first visit? So do you have the paperwork that the patient can fill out for their first visit, so they don't have to get there and then get this clipboard and fill out all this information? Let them do it from home. Better yet, let them fill the form out online and submit it online. But at the least, let them print it out and fill it out at home. Do you have bios? So one of the things we had here was bios of our specialists, so they could print out a bio sheet. If they're making a referral to a specific specialist, they could print out the sheet with a picture of the specialist and an introduction to that specialist, so that the patient feels like they've already met that individual. We also had links to videos that you can watch and meet the specialist through the video. So I mentioned the phone number was the big issue. So these went in the back office where the administrative people work. Huge. These are big stickers. Number one was getting that phone number out there in front of these people. And then here, these are resources for a better patient experience. And again, we're talking to the doctor or somebody working in the practice, a physician extender or an administrative staff member. And so here are all the different things. We even had talking points for the doctor. So if you're making a referral to Floating Hospital for Children and the patient says, well, why aren't you sending my child to Boston Children's? We had talking points for them to help them be comfortable making that referral. And I think that's a must. I mean, if you are not the dominant brand in your market, helping the physician to be able to make that referral confidently, it needs to be done, and you need to do it. You can't just assume that they're going to do it because they like your physician liaison. That's not going to happen. And then the most popular piece, when we went back and surveyed physicians after this was done, the most popular piece we produced, and they could download from the website again, was a quality piece about quality and patient safety, where we gave the quality metrics for all the major hospitals that Tufts competed with, and Tufts, and we showed the difference between the organizations, and we showed that Tufts was the quality leader in the Boston Metro. Doctors loved that. Patients wouldn't know what to make of this, but doctors loved it. And the problem with a piece like this is, quality metrics change all the time, so we were constantly having to update it. That was the challenge, but it was a phenomenal piece for physicians. So this is what the campaign looked like as an overview. We had posters in the lobbies. We had the Let Us Be Your Guide. That's the first visit guide. We had Post-its. We had little pads. One of the coolest things we had over here was a whiteboard that you would put on the back of the exam room door. So you know how they walk you in and then they leave you as the patient in the room? So the doctor could write messages on there. Have you had your flu shot? Check out this website, and put a URL on there, or, whatever they want to put. But certainly put a URL in. And the doctors I know who have done this and stuck by it say they will walk in the exam room and the patient is on their phone checking out the websites that they've recommended. So it's a cool thing. I stole this idea. Every idea I have stolen. I don't think I have many new ones, but this I stole from a woman, a pediatrician, Dr. Natasha. She's fabulous, and I love this idea. And this is the pediatrics version. So you have adult and pediatrics. So hopefully the patient has seen all this. They go into the exam room. They're more comfortable with the idea of Tufts or Floating Hospital for Children, and you hit a home run with the referral. Or at least you hit less resistance. So that was Tufts. How am I doing on time? Cool. The most recent project we've been working on, and this is an evolution. Tufts was very different from Cooper. And Tufts, some of the things Tufts was missing that Cooper had that Tufts did not was the social media element of it, Twitter, LinkedIn supporting it, the blog supporting the campaign. So the difference in actual, not ROI, but results. The Cooper microsite for the Cooper campaign that spoke directly to physicians. Remember, consumers did not have any reason to go to this site. They didn't know it existed. We had over 3,000 unique visits, a quarter on that website. And we're talking doctors. I mean, there weren't that many doctors in South Jersey, so we're getting a lot of repeat visits from physicians. Whereas the Tufts microsite for the physician campaign had about that same number in a year. So about 3,000 visits in a year. And I think the big difference was the Cooper microsite, and that whole campaign was based on delivering sophisticated information to those doctors. Not just making it easy for the patient, which the Tufts campaign did, but Cooper was all about let's give them the newest, latest information, what's happening in the medical world as it relates to Cooper, which was interesting, and that information was always being updated. The Tufts microsite was really just a resource center, and the content didn't change much. And you guys who work in the digital world know if you're not changing out your content, you're becoming irrelevant pretty quickly. So I think that was the difference between those two programs primarily. So my friend Lyle Green, who's a very famous physician relations expert, he was the VP of marketing for MD Anderson, or VP of physician relations for MD Anderson Cancer Center for, I think 28 years or something. He's now retired from that, and he's doing consulting. But Lyle and I wrote this article we wrote for a number of publications about the digital future of physician relations. I flew to MD Anderson on his invitation, and he saw this raging blog post I'd written about it was something like physician relations is in the dark ages of marketing or something. And he loved the article and wrote back to me and said, we're actually doing some cool things at MD Anderson. Why don't you come out and hang out with us? So I went out there and we had a physician relations summit with physician relations experts in the Houston area and his team. And we spent the day saying, what would the future look like for us in physician relations? If we could just start over, what does that future look like? What can we create? And that's what we did. I mean, and I love that about this guy, Lyle. He's willing to do anything. He's willing to push the envelope and try something new and not ask permission. Just do it and see if it works. And together we created a pilot program to start having physician liaisons use Twitter to reach out to physicians in addition to doing their everyday job. So the questions we were asking is, how can we expand the role of the specialist? How can we get ahead of the curve with digital? Because even though only maybe 10% of all physicians are on Twitter today, in 5 years that might be 50%. And that's just one digital platform as an example. So how can we get ahead of that curve? And how can we use digital technologies to drive growth for specific programs? So those were the kinds of things we were trying to address. And as we talked, we spent this day talking, and there were a bunch of physician liaisons in the room, and I presented this same presentation to the American Association of Physician Liaisons. I faced them, looked them right in the eye, and they loved this. They were on board. Now, they were excited because the cocktail hour was right after my presentation, so that might have had them in a good mood, but they understood what I was talking about. So the cool thing is, content aggregation, which is so important in what we do with websites, making sure we have great content, that's always been something that physician liaisons and physician relations people do. They get together their brochures and pamphlets and newsletters and take them out to these practices. They do it kind of the old school way. And what we started thinking was, maybe these can become content aggregators on the digital side, so they can start pulling together. Think of the wealth of information in your health system, and frankly, how hard it is to gather all that information. But if physician liaisons could start saying, you know what, I'm going to be the one that links doctors to all that digital content that we have at our medical center that's so cool. I'm going to create that link. It's a natural role for them. They're used to playing that. They're not used to being on Twitter, maybe, or whatever the platform is you want to use, but they're used to playing that information connection role. So we decided there are two paths we could follow. And I'm sure there are a million paths, but the two most likely paths we chose were, one, have the physician liaisons start doing social media as part of their job every day, reaching out to area physicians and other healthcare professionals, people in the practices. The second would be, and it's not quite as extreme, You hire one person who works in the physician relations department who is your digital specialist, basically. They're the content aggregator and distributor. Their job is to seek out that information across the medical center, across the hospital, gather it together, and then disseminate it and tweet out links or share links to that information and connect those referring physicians with all the great things your medical center is doing through digital platforms. So there were two paths to go. What Lyle and I decided was to do a pilot project around empowering the actual physician liaisons to start using Twitter. And we took 2 physician liaisons to start out slowly, and we trained them on how to use Twitter, and we trained them how to use Hootsuite. Any of you know Hootsuite? So they could schedule their tweets throughout the week, and we turned them loose. But they were very, I don't want to say strict, but it was very regimented. We didn't want them going crazy. We wanted to control the program. So the next few slides, I'm just going to walk you through what that program looked like in case you want to try it at your institution. So it was a 60-day pilot, and our goal was not to get referrals in this pilot. Our goal was to see if this works in terms of can we get the liaisons to integrate this into their job. Is it a realistic expectation? Because these people have been doing their job one way for 100 years. Now we're asking them to start, using Twitter. It's a big change. So we love Twitter, because we see physicians moving more and more towards Twitter. We see physicians at conferences tweeting along at conferences. But MD Anderson in particular, in this case, had over 90 physicians who were on Twitter. They're employed, faculty. So it was a natural choice for us because referring physicians could directly connect with MD Anderson physicians on Twitter. What great access. You want to meet a physician? Start tweeting together. So that was a natural thing. MD Anderson also already had, because my friend Lyle is such a crazy guy and such a risk taker, they already had a Paperlis daily newspaper. Do you guys know Paperlis? Paperlis aggregates tweets and forms them into a newsletter every day and tweets it out to all your followers. So the physician relations Twitter handle was used, and they aggregated tweets from all the MD Anderson faculty from the prior day, and then it would share them out. So you get every day this digital newspaper of tweets from MD Anderson faculty. So we were already in this domain, so why not continue with Twitter? Criteria, we tried to find 2 liaisons early on who were willing victims, who would let us do this, who weren't terrified of Twitter. It turned out one of them was really great on Twitter. One was a newbie, but she was a good sport and willing to try. And they had very different experiences because of the background they brought to Twitter. And there they are. So we would get them to pre-schedule their tweets for the week, so they aren't spending every day trying to figure out what tweets am I sending. We also I pre-wrote 100 tweets. I call them foundational tweets or evergreen tweets that marketed MD Anderson from a physician's perspective. What would a physician care about? How to access information about clinical trials in the world of oncology. So I wrote 100 of those tweets. I didn't want, during this pilot project, they're sort of learning how to use Twitter. I didn't want them having to worry about how to write tweets. I wanted the tweets done for them. And I also didn't want them to take a lot of license with writing tweets. I wanted it pretty regimented. So they had the tweets pre-written. The times when we would depart from that were if they were at a conference and they were saying, come by the MD Anderson booth, meet Dr. So-and-so, that was different. Daily, what we wanted them to do, because, scheduling tweets is great. Having pre-written tweets is great, but it's not very authentic and credible. So what we wanted is to bring that authenticity to the program. So what we did ask them, you've got your tweets already scheduled for the week. You took an hour on Monday, you scheduled all your tweets. Now, every day, spend a few minutes in the morning and a few minutes in the afternoon checking your Twitter feed and responding to people. Just thank people for the retweet something, that kind of activity. That adds that authenticity. Oh, there's a real person. This isn't just a bot sending out tweets. So we had them do that. So with physicians, and don't ever believe anything you read, including on my screen, about the times of day people tweet. Use common sense. You're human beings. You know what it's like. When do doctors tweet? You know doctors. They're on social media early in the morning and after they're done at the end of the day. That's when they're on social media. And if you're marketing to women, when are most women on Twitter? You know women. You might be a woman. So use your common sense. Don't read these crazy studies where they tell you about, the best time to reach women is right around noon. Everybody's tweeting at noon. Well, let me tell you, most people don't tweet. Over 90% of the people on Twitter never tweet. They're voyeurs, and that is perfectly okay. So when they're giving you data about, everybody's tweeting at noon, because it's the lunch hour, yeah, there are a lot of people tweeting at noon. But when are people looking at their social media feeds? That's what I care about, and they don't publish that data. So, and I'm not smart. I'm a normal person. So if I can figure this out, I know you guys can. See, that's a good one for Jason. Okay, so we targeted the tweets, and because they're scheduled, it was easy. 5:30 in the morning, and then 9 or later at night. And you can reach physicians at midnight. 1 in the morning is not a bad time. And let me tell you something about Twitter. One of my pet peeves. You can take the same tweet and share it 3 or 4 times. Because nobody will see it twice. It's like flocks of geese flying overhead, and it's a different flock every minute. And so you can put the same tweet about whatever it is, your clinical trials, at 5 a.m., at 6:30 a.m., and at 9 p.m. And no one will see the redundancy. People are afraid, well, what if they go to my Twitter landing page and they see, it's like nobody goes to your Facebook page. They never see your Facebook page, and they never see your Twitter landing page. They see the feed. They see their feed with 4,000 other people in there. And how do you gain some attention? You use good hashtags, and that's one of the things we taught these guys to do. So one of the keys, and I'm showing you the good, the bad, and the ugly. One of the failures in this program was that the liaisons didn't change how they did their job. They did the Twitter thing, but they didn't change how they did their job. They didn't talk up digital platforms. They didn't go into the practice, and we coached them on doing this, but they didn't do it. They didn't go in and say, hey, we have 90 doctors now. We had collateral that they could pass out, but they didn't do it. They just were not comfortable changing that aspect of their job. So they didn't market this fact. And it's no good having a digital presence if you don't tell anybody about it. You've got to cross-market it. So, I expect the liaisons, and we've changed this now, we've fixed it, but to walk into the practice and share the collateral and say, hey, I don't know if you're on Twitter, and if you're not, you might want to start thinking about it, because a bunch of our doctors are on Twitter, and it's a great place to interact with them. And they're tweeting about the newest developments in the field. I just did a talk last week in New Hampshire for a group of their primary care physicians, and the whole talk was about educating them about how to use social media for their practice. Think about what a cool marketing tool that would be for a hospital to hold those kind of seminars for community physicians about how to start using digital tools to market their practice and to engage other physicians. And it would position you as a thought leader and being ahead of the curve there. So I think that's a great opportunity. So we used Hootsuite, as I said. We defined hashtags. So in oncology, there are hashtags for every type of cancer you can imagine. So we used very specific hashtags that a referring physician would be looking for to reach these doctors. Let's see what else. Oh, we developed a naming convention for their Twitter handles so that they would have a consistent Twitter handle, and that would become the convention moving forward. We coordinated with their marketing team to make sure we weren't breaking any of their social media rules. So we followed their social media guidelines and got the blessing from the marketing department, because the marketing department, at least at MD Anderson, and the physician relations department are very separate. And we wrote 100 foundational tweets I already mentioned. So evergreen tweets, search MD Anderson clinical trials by cancer type, treatment, physician or NCT number, and the link and at Physician Relations. Some of the hashtags were as simple as oncology, some were much more sophisticated, related to very targeted cancers. So we went in, when we started their Twitter feeds, their Twitter accounts, we went in and told them who to follow. We had a list of about 90 different accounts that we thought they should follow, and most of them were MD Anderson accounts. Each department has their own Twitter handle. There's the library, all kinds of elements within MD Anderson, as you can see here. And also those physicians at MD Anderson who were tweeting most often, we had them follow them as well. So these were people that we knew we trusted, and the liaisons could feel comfortable retweeting the content. Because we didn't want them retweeting just anybody, because as you know, health information is very bizarre online, and some of it is trusted and some is not. So we wanted to define for the liaison what is trusted. And we did original content from medical conferences, activities in the field. We got a new practice opening. We tweet about that. And the liaisons would email me and say, Dan, I need to write 4 tweets about this new opening. Help me out. So we would write 4 tweets. And if you don't write for Twitter, it's hard. I write for Twitter every day. It's easy for me, so I could help them out and save them a ton of time. And that's what we tried to do. Again, we didn't want this to be an interruption. So we took it slow. We started with a small list of people. We started with the evergreen tweets. Our goal was to make it easy on them. And what we learned, obviously, the liaison who was more familiar with Twitter had an easier job of it. He liked it. He understood it. He was much more successful. The one who was not familiar with Twitter really struggled. The biggest challenge they had was with the evergreen tweets. They wanted to write their own tweets. And I kept explaining to them that we don't want to put that burden on them. But they felt it was canned information. They were pushing out canned information. And so that was getting over that hump was the most difficult challenge we faced with them. Because they would complain, we'd do a weekly debrief, and they would complain, this is taking up so much of my time. And I was like, it's supposed to be 20 minutes a day. How is it taking up so much of your time? Oh, well, trying to write these tweets. I'm like, no, do not write tweets. You're cool. Just retweet good content and share the content we've already written for you. All right, let's see. The other really big thing was we had such trouble with the liaisons embracing the idea of passing out the collateral and educating the office staff and the physicians about what was going on with Twitter and with this digital communications program. And that has to happen. You have to have the kind of face-to-face marketing to accompany the digital marketing. The two work together beautifully, and that did not happen in this case. The other thing is you have to have realistic expectations. The liaisons complain like, oh, I only have 3 new doctors referring as a result of this program. It was 60 days. How long in person does it take you to build a relationship and start getting referrals? Right? So it takes a while. So it's the same thing on Twitter. In phase 2, we went out and hired a new liaison who was great at Twitter, who when she was hired, she knew this was part of her job. And she was excited and took the job for that reason, and it changed the whole dynamic. So I think if you're going to build a program like this, it's easier to build it with new employees than someone who's been doing their job forever, and you're suddenly changing their job and actually adding something new to their job. So that concludes my presentation. Any questions?